everyone if you guys could mute yourselves. Presentation.
Yes. Can someone say something real quick? Because I think my headphones are doing something weird.
Can you hear me?
Yeah.
Okay. All right. They're fine. I was concerned because I was like, it was popping up with a message that I did not understand. But we're good. Cool. Well, thank you guys so much for coming tonight. I am going to be talking about bioethics, harm reduction, and COVID-19, which are three topics that are interesting to me and overlap in various ways. I could also have said that race is a topic in this, but you'll see that it sort of threads through the whole thing. Some of you might know I did a master's in bioethics at Wake Forest. I finished in August of this past year, and that was a really fun kind of different thing for me to do. I got to explore classes in with medical school professors, with law school professors, women and gender studies, philosophy, theology, public health, a lot of different things. And so I'm not going to talk too much about bioethics, but just to give it a sort of a framing of how I'm approaching some of this topic. So there we go. So the Principles of Biomedical Ethics is a classic textbook for bioethics and medical students. This is not on my recommended reading list just because it's very dense and you'll get whatever you need to know right now. But in this book, Beecham and Childress outline 4 principles of biomedical ethics, so sort of guiding standards for doing ethics in healthcare. And they are respect for autonomy, non-maleficence, beneficence, and justice. And I'm going to explain each of those. But Maria Theresa Jones often has told me I need to figure out a way to talk about these 4 principles in alignment with John Wesley's 3 simple rules, which are do no harm, do good, and attend upon all the ordinances of God. And I think there are definitely some parallels that we will see. I'm not going to get too much into that, but I just like to mention that. So first, respect for autonomy. So the word autonomy, auto and nomos, means self-rule. And the way Beecham and Childress put it is that to have autonomy is to be free from controlling interference by others and limitations that prevent meaningful choice. So autonomy is both being able to make decisions for yourself, but in a medical setting, it also involves informed consent. So when you're getting a medical procedure, you don't just say, yes, you can do this procedure. They try to inform you about what they're going to be doing, what the risks are, and the potential outcomes. And it's the clinician's responsibility to make sure that you have some understanding of what's going on so that you can give meaningful consent. So one of the limitations that prevent meaningful choice they name is lack of understanding. So that effort to educate is important. And autonomy is pretty much liberty and agency. So having freedom and the ability to choose in your own life. And not all forms of Christianity believe in free will, but I do. Which, with caveats, but that's fine. Non-Maleficence. This is the image I chose of Maleficent, who is the antagonist in Sleeping Beauty, just because maleficence is a word that we don't use a lot. But non-maleficence essentially means not inflicting evil or harm. In biomedical ethics, there may be some things that are done that could in and of themselves constitute harm, but that are for a greater good and therefore are considered ethically okay. For example, I went to give blood recently and they had to do the finger stick to test my iron levels. Well, technically sticking me with a needle is a form of harm, but since it's minor and since it is for the greater benefit of ensuring that my blood can be used, it's not considered unethical. So non-maleficence and beneficence are sort of always held in balance. And sometimes we have to interrogate what is the greater good, and at what point doing something that we might think is generally good, like sustaining life, when does that actually become more harmful than helpful? And they're not easy questions. The other piece of non-maleficence is not imposing a risk of harm. So things like neglect can be considered harm in and of themselves because they might set someone up for risk of harm. Beneficence. So non-maleficence and beneficence are just a little bit different. So non-maleficence is about not inflicting evil or harm, and beneficence is about preventing or removing evil or harm, and about doing or promoting good. So non-maleficence is kind of an absence of something, and beneficence is the presence of removing harm, doing good. And Beecham and Childress say it's a state of moral obligation to act for the benefit of others. I've been thinking about this just in terms of a lot of folks at our church read Ibram Kendi's How to Be an Anti-Racist. And Kendi is very clear that you can't just not be a racist. You have to either you're being racist in your actions, or you are actively being anti-racist. And so I kind of think about non-maleficence and beneficence. Similarly, there's not a lot of room for being neutral, because if you're allowing harm to happen, you're not engaging in beneficence. But you're also not to inflict harm. And then finally, justice. So justice is a broad term and means a lot of different things. In the context of bioethics, we're talking about distributive justice. So it's about how like goods and services and access are distributed among a population, and whether that's done equally. And Beecham and Childress quote Aristotle, who says equals must be treated equally and unequals must be treated unequally. And I think a good example of this is there's still been conflicts coming up on social media around Black Lives Matter versus All Lives Matter. And my aunt delighted me by posting this image where it pretty clearly outlines, we know in Aristotle's terms, everyone is supposed to be equal. If everyone really were equal, we could treat everyone equally and say all lives matter. But people are not all treated people are not treated all equally, and therefore we can't treat people equally. We have to respond to people where they are and where they're positioned in society. It's worth noting there are a lot of different theories of justice that I'm not going to dig into. There, utilitarianism versus, preference to people who are worse off. There are a lot of different ways to think about justice, but the point is that justice should always be in the forefront when dealing with patients or with people in other situations. So to sort of segue into, I'm talking about harm reduction and drug use. And so I would actually be curious if any of y'all want to brainstorm with me just ways, I provided some examples, but ways to engage with these principles when it comes to people who use drugs. And for me, these principles were written for like healthcare workers and clinicians and are very relevant in that situation, but I think that they can be actually helpful also in community and just in engaging with our neighbors. So thinking about respect for autonomy, just supporting the agency of people who use drugs to make their own choices. A lot of times we think of people who use drugs as not having the ability to make choices, but it turns out that sometimes if we just remove some barriers to autonomy, they actually can. Non-maleficence, so thinking about not doing harm, not using stigmatizing language or harmful behaviors against people who use drugs. Beneficence, supporting services for people who use drugs, including overdose prevention. So if overdose is a harm or a risk of harm to someone who uses, for example, opioids, then providing them with naloxone is a form of beneficence to remove or prevent that harm. And then justice as confronting and changing racialized drug policy, which we're going to talk about more. So, and obviously there are a lot of other ways that these principles can show up for people who use drugs, but those are just a couple of examples to show how that's connected. This is a quote that I came across. The author is writing from a Latino perspective on liberation theology and bioethics. And he says, the principal enemy faced by bioethics is not simply death, but premature death and suffering as the fruits of injustice. So in bioethics, we aren't just trying to figure out how to prolong someone's life, but we're trying to figure out how to deal with the realities of injustice and suffering in the healthcare system, but then also more broadly when it comes to public and population health. And I would also say just in the human condition as a whole. And speaking of premature death as the fruits of injustice, so this is a graph of opioid-related drug overdose deaths. And I mean, I think we've probably all seen graphs like these in recent years that these overdose deaths have been going up, and in many places still are, especially when it comes to synthetic opioids. So things like fentanyl that are more and more in the drug supply. Deaths have been on the rise for a number of years now. This doesn't get talked about quite as much, but the same is true with stimulants. So cocaine overdoses and other psychostimulant overdose deaths are also still on the rise. And yes, Heather.
Hey, I just have a question. Can you go back one slide for me?
Yes, I think I can. Yes.
Okay. I think that like I and other people might be confused about like the difference in the dangerousness. That's not the right word, but like of these drugs. And
Yeah.
I don't know. I'm not trying to put you on the spot to answer a question that you weren't prepared to answer.
No, you're fine. I can give you like a very simple answer to that. So,
like explanation would be great.
Yeah. If you can overdose on a lot of things, the question is often like, how hard is it to overdose on something? So you'll see like the rates of methadone overdose are pretty low. Methadone has a pretty long half-life, and I think some of that has something to do with why it's not either it shows up in overdose as much. Really, I think probably the more interesting comparison between like heroin and synthetic opioids. So like fentanyl can be, I can't remember what the number is, but many, many times more potent than heroin. And so a much smaller amount of fentanyl is more likely to cause an overdose. And I'll note too that a lot of what I hear people talk about is that, you know, when you have a society where certain drugs are prohibited, then if people are using and buying those drugs, they don't necessarily know what they're getting. And I've had people ask me before, like, you know, what about like personal responsibility when it comes to drug use? And it's like, well, most of the time, if we're putting something in our bodies, we have a label and we know what it is. And it's just not possible for people to know a lot of the time. And so I'm not sure. I know that like even locally, we've been having more like fentanyl laced cocaine, opioid overdoses, but people who were using cocaine and were not expecting to encounter an opioid in their drug. But with fentanyl and other synthetic opioids, they can often be extremely strong. But it is worth noting, little myth busting moment, there have been reports that you could overdose just by touching fentanyl, and that's not the case. So there's been misinformation about that there. I don't know if that really answered your question. Yay, good enough. Some are stronger than others. Some of these drugs are more enjoyable to use in larger quantities and are more likely to be used in larger quantities, as I understand it. And I know less about non-opioid overdose, but that is a problem that continues. So the approach that I've been working on embracing in response to drug use is harm reduction. And so the National Harm Reduction Coalition gives sort of like a two-part definition of what harm reduction is. So harm reduction, big H, big R, is a movement for social justice built on a belief in and respect for the rights of people who use drugs. And then harm reduction, little h, little r, is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. So little h, little r are things like giving people sterile supplies or sterile syringes to inject drugs and connecting people to treatment, these very practical things. And it's worth noting that you can engage in harm reduction little h, little r without engaging in harm reduction big H, big R. There are services out there that provide practical needs and supplies to people who use drugs, but that don't have an attitude of respect for their autonomy and their rights. And that can be problematic. And I appreciate this sort of like dual reminder that there's the practical things that we do for people, and then there's this bigger social justice movement that we'll touch on a little bit more as we go. Harm reduction meets people where they are. I like this quote from Gary Stimson. Harm reduction is based in public health. There's strong evidence for its effectiveness. The scientific debate in this regard has been won. And harm reduction is based in human rights, the right of all people to the highest attainable state of health. So we're talking about public health, but we're also talking about human rights. And I think it's important to hold both of those because it can be easy to almost unintentionally reduce people to public health statistics or focus on serving them only in relation to their ability, their potential for spreading disease or something like that. But we need to be able to treat people with dignity and respect and work for their human rights as well. Mentioned a couple of these already, but here are some of the little h, little r harm reduction strategies: syringe access and disposal, safer drug use, referrals, naloxone, which is the opioid overdose reversal drug. Housing is a form of harm reduction. A lot of people who are experiencing homelessness and use drugs are more likely to have an infection or perhaps to be alone and overdose or not have access to quality health care. Medication-assisted treatment. This is primarily when it comes to opioid use. There are a number of different medications that can be prescribed to people to help curb cravings and prevent overdose. And I don't know as much about I know that there are things out there for stimulants and even for alcohol, but I know less about those things. And then supervised consumption sites are not currently legal in the US, but have been established and shown to be effective in other countries. And that's basically, it's a place where people can come and either inject or smoke the drug of their choice and have access to sterile supplies, and then have nursing staff or other people around, basically just keeping an eye out and making sure that everybody is okay and safe. And those have been really effective in places like Vancouver and other big cities that where people sometimes just need a safe place to be and do what they're going to do anyway. One important thing in harm reduction is to think about substance use on a spectrum. And I think it's important to note, sometimes you'll hear folks talk about kind of like harm reduction or abstinence-based recovery as kind of like two very different separate approaches, but really abstinence-based recovery is part of the harm reduction spectrum. It's part of the substance use spectrum. And we've got a lot of good friends that work closely in both traditional recovery communities and in harm reduction. I think that's really important to note. And I know for me, I think, as someone who does not identify as a drug user, when I think about especially drugs we think of as hard drugs, I think of either you're using them all the time and they take over your life and they're really harmful, or you don't use them at all and you stay far away from them. But as it turns out, there are a lot of people who are recreational users of these drugs that we think of as being so dependence forming and chaotic, and that even people who are in chaotic use with the right support and with their own desire and agency can shift to less chaotic places along this spectrum. And a lot of what harm reduction supports is to say, we support any positive change in your use. And that could include if you're injecting heroin and that creates a risk of infection or overdose, even if you just started snorting instead, like that would be a positive change. And might hope for other steps along the way, but recognizing that there are a lot of things that people can do to improve their own health and improve their own lives, and that all of those steps are worth celebrating along the way, and that everybody's journey is different. There's not a one-size-fits-all solution to substance use problems, and we need to be able to honor people's autonomy in the process. I thought I heard a knock. So the Harm Reduction Coalition outlines 8 principles of harm reduction, and some of these kind of go back to the principles of bioethics, but I have put together an abridged version. All of these are kind of like a long sentence, so I put this like abridged version together. So the first principle is that drugs happen, and the idea behind this is that drug use is a reality that exists. We can't just pretend that it doesn't happen or wish that it wouldn't happen or just tell people not to use drugs. People use drugs, they're going to use drugs. We're better off if we just acknowledge that and then say, okay, what next? Number two is that it's complicated. There are a lot of reasons that people use drugs. Sometimes it's related to trauma or mental health. Sometimes it's just because it feels good. There are a lot of complicating factors that can make someone's drug use problematic, and we need to be able to approach people in their own context of their lives. Number three is quality of life first. So a lot of times if somebody has a drug problem, we get really focused just on the drug itself and on reducing their use or stopping their use, when really it can be more sustainable for people to focus on, what do I want my life to look like? What do I want my career to look like, my family, my free time? And then, okay, if my drug use is standing in the way of that, how can I make steps to change that? Not just so that I can stop using the drug, but so that I can, live the life that I want to live. I think that's important. It's been a while since I've looked at this, but I think I'm pretty sure that in the 12 steps of AA, there's only one step that actually mentions alcohol. All of the rest are about kind of working on ourselves. So is that correct? I think. Yeah. Cool. So that focusing on the broader holistic life is really important. Number four, no judgment. There's a lot of stigma and judgment about drug use out there, and it never helps people make better choices. It only ever hinders that and hinders relationships. So it's important to set that aside. Number five, nothing about us without us is actually a phrase that came out of the disability rights activist movement that I've borrowed. And the idea of this is that directly impacted people, either people who use drugs or have used drugs, need to be involved in decision-making around policy and programs that are for them. If I were to just try to design a program for drug users, I would not do a very good job, because I might think I know what they need, but I don't. And so it's important to involve directly impacted people in all of these decisions. Number six, power to the people, kind of similar, but also just saying that people have agency to make change in their lives, and we need to respect and honor that and empower them to make those decisions. A lot of the sort of policies and usual responses to drug use that we have in place in society make it harder and not easier for people to make change, and we need to work on that. Seven, inequality is a reality. So there are discrepancies in race and gender and sexual orientation, all kinds of things, as to class, especially economic realities, as to how much drug use might or might not interfere in someone's daily life, or whether it might bring them in touch with law enforcement and the justice system. And we need to be real about those inequalities and face them head on. And then the last principle I summarize it as drugs hurt, but the idea is that harm reduction doesn't say that drugs are good or bad. Harm reduction acknowledges that drugs are there, that people use them, and they recognize that there are real harms that come both from drug use and from societal responses to drug use, and it's important to name that. And that's from the Harm Reduction Coalition. So importantly, the Harm Reduction Coalition is committed to healing the harms caused by racialized drug policy. Harm reduction as a movement really started out of communities of color and queer communities during the HIV/AIDS epidemic, and those sort of radical roots are really important to what's happening today, even as harm reduction is becoming more popular, especially in white communities. And I love this quote by Monique Tula. She says, "Harm reduction alone cannot heal the harms of the drug war without bridging the divides it has caused. We live in a world where the presumption of guilt and criminality follows nearly every Black and brown person every day." And the statement at the top is called their North Star statement. The rationale for this is the importance of remembering who historically has borne the burden of oppressive racialized drug policies. We are loudly proclaiming that we will never forget. And just an example of some of the historical stuff. So this idea of like the Negro cocaine fiend was a big thing, that cocaine made particularly Black men a lot stronger and impervious to bullets, all these myths. The bottom left one is a little hard to see, but this sort of monster creeping toward the USA says Oriental dope problem on his arm. And then we've got this one about the Mexican nation locoed by a peculiar weed. So there's deeply racist ideas around particular drugs associated with particular immigrant groups and with Black people. And those have informed a lot of the drug policies that we have today. A great example are mandatory minimums, our mandatory minimum sentences for crack cocaine are much higher than for powder cocaine, and crack cocaine has historically been associated more with Black communities. Otherwise, there's absolutely no reason for those to be considered any differently. They're chemically the same. I wanted to just show this video partly because I just think it's really well done. Jay-Z narrates it, and there's really cool illustrations. I know Zoom is a little hit or miss on video, but we'll give it a try. And if it doesn't go well, I'll just send you the link. So.
In 1986, when I was coming of age, Ronald Reagan doubled down on the war on drugs that had been started by Richard Nixon in 1971. Drugs were bad, fried your brain, and drug dealers were monsters. The sole reason neighborhoods and major cities were failing. No one wanted to talk about Reaganomics and the ending of social safety nets, the defunding of schools and the loss of jobs in cities across America. Young men like me who hustled became the sole villain, and drug addicts lacked moral fortitude. In the 1990s, incarceration rates in the U.S. blew up. Today, we imprison more people than any other country in the world. China, Russia, Iran, Cuba. All countries we consider autocratic and repressive. Yeah, more than them. Judges' hands were tied by tough on crime laws, and they were forced to hand out mandatory life sentences for simple possession and low-level drug sales. My home state of New York started this with Rockefeller laws. Then the feds made distinctions between people who sold powder cocaine and crack cocaine, even though they were the same drug. Only difference is how you take it. And even though white people used and sold crack more than black people, somehow it was black people who went to prison. The media ignored actual data to this day. Crack is still talked about as a black problem. The NYPD raided our Brooklyn neighborhoods while Manhattan bankers openly used coke with impunity. The war on drugs exploded the U.S. prison population, disproportionately locking away black and Latinos. Our prison population grew more than 900%. When the war on drugs began in 1971, our prison population was 200,000. Today it is over 2 million. Long after the crack era ended, we continued our war on drugs. There were more than 1.5 million drug arrests in 2014. More than 80% were for possession only. Almost half were for marijuana. People are finally talking about treating addiction to harder drugs as a health crisis, but there's no compassionate language about drug dealers. Unless, of course, we're talking about places like Colorado, whose state economy got a huge boost by the above-ground marijuana industry. A few states south in Louisiana, they're still handing out mandatory sentences for people who sell weed. Despite a booming and celebrated 50 billion legal marijuana industry, most states still disproportionately hand out mandatory sentences to black and Latinos with drug cases. If you're entrepreneurial and live in one of the many states that are passing legalized laws, you may still face barriers participating in the above-ground economy. Venture capitalists migrate to these states to open multi-billion-dollar operations, but former felons can't open a dispensary. Lots of times those felonies were drug charges, caught by poor people who sold drugs for a living, but are now prohibited from participating in one of the fastest growing economies. Got it? In states like New York, where holding marijuana is no longer grounds for arrest, police issue possession citations in black and Latino neighborhoods at a far higher rate than other neighborhoods. Kids in Crown Heights are constantly stopped and ticketed for trees. Kids at dorms in Columbia, where rates of marijuana use are equal to or worse than those in the hood, are never targeted or ticketed. Rates of drug use are as high as they were when Nixon declared the so-called war in 1971. 45 years later, it's time to rethink our policies and laws. The war on drugs is an epic fail.
I was muted. It's a pretty quick overview, but just to give a sense of the history of the war on drugs and why it has led to mass incarceration. So Michelle Alexander's book, The New Jim Crow, she says, nothing has contributed more to the systematic mass incarceration of people of color in the United States than the war on drugs. And then this graph over here on the right is a rate of incarceration by race and ethnicity per 100,000 population. And so Black people are incarcerated at a far higher rate. We have extremely high incarcerations on the whole. We have 5% of the world's population and 25% of the world's prisoners. So it's already a problem here. and it's more of a problem for people of color. Now this is relevant to what's going on in the world right now. George Floyd died while an officer joked, "Don't do drugs." And there may have been suspicion of drug involvement that led to him being held the way that he was, and then led to his death. And so this image is from the Drug Policy Alliance, and they pointed this out and said drug involvement is no excuse for the maltreatment of people of color, and there is no excuse. So this is relevant to what's going on with COVID for a lot of different reasons. One of them is that there is this decarceration movement that has been going on anyway, but has become a lot more urgent in the pandemic. The idea being that it's impossible to socially distance when you are in prison. And there are a lot of people, especially people of color, who are incarcerated for low-level nonviolent offenses, who are, and many, many people also who are immune compromised, who are now being put at greater risk of infection and death from COVID-19. And so a lot of activists have been arguing that people should be released from prison and jail, and to get better access to healthcare in the prisons as well. COVID-19 has been disproportionately affecting Black and Brown populations. This chart it's just from New York City, but there have been similar trends in other places. And you'll see there are higher rates of Black and African Americans who have contracted the virus, who have been hospitalized, and who have died. Okay, so, and it's been interesting to see even locally how the pandemic has affected harm reduction services. So Twin City Harm Reduction Collective is housed in Green Street Church, and they've gone entirely delivery for the pandemic. They'll probably need to reopen their fixed site at some point soon, but have not yet worked out a plan for how to do that safely. And a lot of syringe exchanges have either had to scale back or shut down their services. And so that it's harder to get supplies to people. It's also harder to just have contact with folks and to, hear what's going on with them. And this quote, the ability to do social distancing is a social determinant of health. So as soon as the CDC started coming out with these recommendations to shelter in place, to social distance, a lot of activists were pointing out, if you're homeless, it's hard to shelter in place. If you're, living in a situation where there are a lot of people coming and going who don't have other places to be, it's hard to social distance. And harm reductionists pointed out that social isolation is actually a risk factor for overdose. And so there's sort of these conflicting values in place of, if a person is using drugs, then being alone is dangerous, because if you can't reverse your own overdose, you need someone to be there to help you. And so a lot of people are having to make these sort of risk trade-offs in this moment. I haven't talked a lot about like religious stuff or church stuff, but I am involved in this national group called Faith in Harm Reduction that's connected with the Harm Reduction Coalition. And by the end of this month, we will have a toolkit for faith communities who want to be better allies to people who use drugs and people who trade sex. So we're in the process of developing that right now. But these are just some images that Faith in Harm Reduction has put out. Harm reduction is the greatest commandment in action. Love one another. And then this one most recently after George Floyd's death, God is saying, let my people breathe. Acknowledging that faith and ending white supremacy and racism and overdose are all connected right now. These are just a couple of books that if people want resources to learn more about substance use and harm reduction, but I feel like I've already talked longer than I intended to, and I would love to have more of a conversation. So if folks have questions or comments or stories or whatever, I'd love to get into that now.
So I wanted to say that early on in your really excellent talk, Sarah, and thank you so much for all of this. But early on, you were saying something about how since drugs are not regulated, people don't always know what they're consuming. And so one of my great uncles, who I never knew, but one of my great uncles died of basically an alcohol overdose during Prohibition because he was drinking moonshine.
Mm-hmm.
And this is a very white story about my very rural family. like, I think if we all dig just like this much, like we can find someone in our lives who has had like, you know, not just a struggle with addiction, but just like a struggle with like bad
Something,
labeling.
yeah,
I mean,
and something related to prohibition. I mean, yeah, it is, it's something that we take for granted a lot, but that I think affects a lot more people than we maybe realize, or in ways that we don't always think about.
Well, I think that like there was sort of like a family joke that he like just drank too much and like died, but like really what happened was that he didn't know what he was drinking.
Mm-hmm.
You know?
I remember a year or two ago hearing about like a province in, I think, India, where they had outlawed alcohol and people were making their own, and it ended up being this really horribly toxic substance that was killing a lot of people. And I mean, I think that's so illustrative of, you know, we tried prohibition with alcohol in this country and it really backfired. And then if we look closely, like a lot of the same problems emerge with other drugs as well. And we need to figure that out and, you know, not pretend it's people's own fault for not knowing what they're getting. Yeah. And actually it was interesting, Colin and I were talking earlier about, so this all connects in with like this whole conversation now about policing, because, you know, there's all this stuff about mass incarceration that's really obvious, but a huge proportion of like robberies and burglaries are at least in some way related to drugs, whether it's alcohol or other drugs. And there's sort of a question out there on harm reductionist parts that like if people just had access to, you know, safe supply reliably, like might that change crime rates in this country, or just make people safer in general? And that's a hard sell for a lot of people, but I mean, there are a lot of other countries that have made moves like that to decriminalize certain substances, and have seen, not immediately, but after a while, have seen improvements in those measures.
Yeah. And I think it's important also just to like talk about the fact that like addiction is not just about substances. Like
Mm-hmm.
addiction is also often about like, you know, sorry, Morty is seriously. But like when I hear about like addiction and harm reduction, like I'm also hearing like a story of my own
Mm-hmm.
self, you know, of like disordered eating and like depression and like, you know,
Yeah.
all like it's all wrapped up in there. And like, you know, like the work of harm reduction seems like not just connected to anti-racism, but also like about anti-racism, and like
Yeah.
it's not just connected to like you know, being like anti-sexist, but it actually is anti-sexist.
Right. Yeah, it's like the problem isn't drugs. The problem is like systemic injustice and trauma and, you know, lack of community.
Yeah.
And it is amazing how many other things start to resonate when you get to like those deeper levels of issues. Yeah.
What do we do when we feel like things are out of control or alone? Like we just try to like control things, you know?
Yeah. And my way of doing that might look more socially acceptable than someone else's, but that doesn't make it any different.
Right. Like my way of doing that is actually legal. Like
Yeah.
you know?
Right.